Hello and welcome for joining. We will be starting momentarily, so hang in tight. I see questions on the chat box asking whether we've started. We'll be starting shortly, so please hang in tight. We're just waiting for a few more people to join. Hello, everyone, and welcome. Thank you for tuning in. I truly hope it's a good morning, a good afternoon, or a good evening from whichever corner of the world you're joining us from. My name is Lydia Murithi, and I'm the director of the Beyond Bias project at Pathfinder International, and I'm based in Washington, D.C. I'm excited to welcome you to the kickoff of a two-part webinar series intended to disseminate Beyond Bias evaluation findings, lessons learned, and their implications on adolescents and youth sexual and reproductive health programming. This is a this two-part series starts with today's discussion on the impact of the evaluation results and their implications. And this will be followed in a few weeks by the launch of the how-to guide for scale of the Beyond Bias model. So please be on the lookout for the announcement of the launch coming up soon. Okay, with that preamble, let's get on with our agenda for today. As I've mentioned, our focus today is primarily on the impact evaluation of the Beyond Bias model or intervention. In our presentation, we will provide you with an overview of the Beyond Bias project approach and the intervention, and we like to call, or we also refer to the intervention as the Beyond Bias behavior change strategy. We'll also describe the evaluation design and methods, present study results and implications, and share our reflections on future work around this topic. Now, we do hope to have an engaging Q&A session at the end of the presentation. So please do submit your questions and comments through the chat box or through the Q&A window. I have the pleasure of being joined by three of my colleagues today, or three speakers today. I'm joined by Gwen Hainsworth, who is a senior program officer at the Bill and Melinda Gates Foundation. Gwen is a mastermind behind this investment. She actually authored the RFP and has remained an invaluable thought partner throughout the course of this work. I'm also joined by Mohammed Brooks, who goes by Bram, and he is a senior monitoring, evaluation, and learning advisor at Pathfinder. Bram serves as the MEL lead for Beyond Bias. Finally, I have Zach Wagner, who is a policy researcher at RAND Corporation. Zach is the PI, or the principal investigator on these evaluation study. And now I'll hand over to Gwen to share some remarks on the importance of this work and why it was worth investing in the first place. Welcome, and over to you, Gwen.
Thank you, Lydia. Good morning, good afternoon, good evening, everyone. It's truly a pleasure to open up this webinar focused on tackling provider bias towards serving young people with contraception. Next slide. Many of us are familiar with the stats on this slide around adolescents and youth having high unmet need and low use of modern contraception. Numerous studies across different country contexts have shown that provider bias and judgmental behavior can be a major barrier to young people's use of contraception. And we know that providers are most often members of the communities that they serve, so they often uphold the same values and norms of their community. This can translate into providers being unwilling to serve a young unmarried adolescent with contraception, or encouraging a newly married young woman to have a baby first before initiating a method. It can also lead providers to discourage the use of certain methods that they deem inappropriate for adolescents and youth, such as injectables or LARCs. Despite provider bias being a pervasive issue, as a field, we've largely relied on training and sometimes one-off value clarification exercises as a solution. However, these have had marginal success in actually changing provider attitudes and behaviors. So in 2016, the foundation made an investment to Pathfinder and its partners to deepen our understanding of bias and to develop and test innovative and scalable solutions to address provider bias and improve the quality of contraceptive services for young people. We are specifically interested in testing solutions across different country contexts and within both the public and private sectors. Our hope was that this investment would increase global and country attention to the issue of provider bias, as well as generate new evidence around other potential solutions. And I have to say, looking back over the last 5 years, so much has been learned over the course of this investment. And we're really excited to be able to share with you today some of that learning, along with the Beyond Bias evaluation results. And so with that, I'd like to hand it back to Lydia to provide an overview of the project.
Thank you, Gwen. As Gwen has very well articulated, the Beyond Bias project was conceived with a mandate pretty much to disrupt the status quo, given the limited success of conventional training and supervision of providers. So the goal of the project was to design and test scalable, innovative solutions to address provider bias towards serving youth with family planning services. And we worked in Burkina Faso, Pakistan, and Tanzania. We employed a multidisciplinary approach combining HCD, or the human-centered design, segmentation analysis, behavioral economics, and adolescents and youth sexual and reproductive health evidence and best practices to respond to this enduring barrier to care. Here's a snapshot of our user-centered process that began with a research phase, followed by the intervention design phase that employed the HCD approach, and then on to the implementation phase. Our discussion today centers around the pilot and evaluation stage of the implementation, and that's presented by the light green bubble on the right side of the diagram on your screens. Now, we've previously had a number of detailed presentations on the intervention design, and the recording of one such event hosted by FP 2020, now 2030, is available on YouTube and also presented on our website. So for those of you who may have missed our previous events and are interested in an in-depth breakdown or understanding of the model and our design process, you're more than welcome to check that out. But for today, I will provide a very brief overview of the intervention just to situate or to help situate the discussion on the evaluation. So very briefly, the Beyond Bias intervention integrates 3 solutions that guide providers through a journey where they activate their drive to serve youth, apply learned knowledge on unbiased care, achieve recognition for their improved services, and become advocates for the youth. Next slide. The provider journey starts with a summit, which is a story-driven event meant to activate providers' awareness of their own biases and build empathy towards young people's needs. This is done through a process of guided reflection, which we also refer to as humanizing bias. Next slide. After the summit, providers are enrolled into the Connect, which is an interactive shared learning forum where providers share experiences and problem solve with their peers. Connect forums are run digitally on WhatsApp or through in-person meetings, and sometimes a blend of the two. Next slide. The third pillar of the intervention is known as the rewards, which is a non-monetary performance-based incentive assessed through client feedback. So we use the client exit survey to be able to assess who is performing or provider performance and who and which providers to reward. Next slide. Together, these 3 pillars form a robust behavior change strategy, which is displayed or projected on your screens right now. And it is this behavior change strategy that we'll be hearing of how it's performed, or we'll be hearing about the performance of this model later from Zach in our discussion about the evaluation. Now, obviously, this is a quick and abbreviated overview of the intervention. But again, as I mentioned, if you're interested in more details about the intervention and the design process, please do check our website. Next slide, yes. Moving on, let's now look at the study setting. As I earlier mentioned, we worked in 3 countries, Tanzania, Burkina Faso, and Pakistan. In Burkina and Tanzania, we worked in public facilities with multiple FP providers. In Pakistan, we worked with private providers who ran their own individual clinics and offer a broad range of other health services alongside family planning. Our study sites were mostly in urban and peri-urban settings, but we also had some facilities in rural areas, particularly in Burkina and Tanzania. It's also worth noting that in Tanzania and Burkina, Beyond Bias was layered upon or on top of platform projects that included training of youth-friendly services as part of their scope. Next slide. In terms of timelines, we rolled out the pilot towards the end of 2019, but were forced into a 6-month pause period due to COVID. We then restarted the RCT in September of 2020 and implemented for 12 consecutive months through August of 2021 in all 3 countries. I would like to point out that the delays in rollout pre-COVID in Burkina were due to a countrywide healthcare provider strike that had lasted for over 6 months. It's also worth noting, or I'd like to draw your attention to the timelines on data sources. We'll be hearing more about data sources shortly, really, from Bram, but for the purposes of a visual summary, as indicated on this table, we collected client exit survey data throughout the implementation period, as these data sources were used to implement the reward pillar, as described during my comment on the intervention itself. Well, other data sources, including mystery clients, provider surveys, and qualitative interviews were implemented at Endline. Additionally, service data were collected service data used through the analysis were those collected through from September of 2019 through August of 2021. Now I'll hand over to Bram to discuss study design and methods. Over to you, Bram.
All right, thanks so much, Lydia. I'll spend a few minutes providing a quick overview of the evaluation methodology and the different data sources used as part of the study. Next slide, please. So what's neat about the study design is that the evaluation team used a mixed methods approach with both quantitative and qualitative components. For the quantitative component of the study, we used a cluster randomized control trial to assess the evaluation impact. In essence, we randomly assigned half of the clinics to receive the Beyond Bias intervention and the other half assigned as control. And as we collect data from health providers and clients, we're assessing the impact of the evaluation on 4 main outcome domains. The first one, looking at attitudes and beliefs of the providers. Second one, the patient-centered care for FP services. The third one, FP methods dispense. And finally, also client perceptions. In addition, we also had strong qualitative components to help contextualize some of our findings. Next slide, please. So to collect data from real clients, we conducted client exit surveys throughout the life of the project using youth enumerators. We use youth enumerators so that women would feel comfortable providing responses to the questions asked in the survey. The youth enumerators were assigned to clinics for about 2 to 3 days a week throughout the life of the intervention, which meant that we had a very high sample size for this particular data source. And as you can see from the bottom of the slide, we had over 32,000 observations from youth respondents ages 15 to 24 across our 3 countries. Data collection started a few weeks before the start of the Beyond Bias intervention, which meant that we had some baseline for this data source. And the client exit survey collected information on demographics, questions asked by the provider, services offered, and measures about the subjective experience of the client from their interaction with the provider. Next slide, please. We also use mystery clients in this evaluation. We train enumerators to pretend to be real clients to visit the clinic and record data on their experiences. So we had 4 visits per clinic in Tanzania and Burkina, with each visit for a different profile. In Pakistan, we only had 2 visits per clinic, and we were worried that the mystery clients would be discovered in this setting due to the lower client volume in a setting where we only had 1 provider in each clinic. In Tanzania and Burkina, we had 8 different profiles that were created that had variation in marital status, parity, and age of the mystery clients. And so we used all combinations of these factors so we can isolate the effect of each of these attributes in our analyses. And in Pakistan, this design was not feasible because some profiles were deemed not socially acceptable, such as unmarried clients with children. So we only used 3 profiles in this country context. We randomly assign these mystery client profiles across the clinic so that there was balance between treatment and control. And in addition, we also assigned clients to have a preference for long-acting methods to see how preferences affect care and also help with some of our analyses associated with preferred method of choice. Next slide, please. All right, we have a somewhat busy slide here with a busy table of information, but in essence, we're trying to show the sample size for the 8 different mystery client profiles, which you can see in the first column, and the combinations of the different attributes for age, marital status, and parity. A few key takeaways from this table. We distributed the sample size equally across the different profiles in Tanzania and in Burkina. And in Pakistan, we only had 3 specific profiles. The first one being the client that was younger, unmarried, and had no children. The second one being the client who was younger, married, and had no children. And the third one being the younger, married, and having 1 child profile. So for this particular data source, we had a total of over 750 mystery clients across the 3 countries. Next slide, please. The evaluation team also collected data from health providers. There were 2 instruments as part of this data source, a provider survey and a discrete choice experiment, or DCE tool. The provider survey captured data on providers' demographic characteristic, attitudes and beliefs about young, unmarried, or nulliparous FP clients, and details about the clinic environment that they work in. The DCE presents hypothetical scenarios about a client and their self-reported behavior around FP service provision. So for example, if a hypothetical client who was 20 years old, married, and had no children presented themselves in their clinic, how would they counsel this individual and what FP methods would they offer? The provider survey had a sample size of over 600 providers across the 3 countries. Next slide, please. The evaluation also collected FP service statistics from each facility from the different health management information systems across the 3 countries. In Tanzania and Burkina, monthly FP service data comes from the national DHIS2 platform, while in Pakistan, these data are collected by Green Star, the social franchising network that enrolled clinics as part of the Beyond Bias project. This data source records information related to the monthly number of new or returning FP users, disaggregated by age and the types of FP methods. And this data was collected continuously throughout the life of the project. Next slide, please. And finally, the evaluation team also conducted a lot of qualitative data, including interviews with approximately 70 youth clients and 30 providers in each country to document experiences with FP care and their interaction with the Beyond Bias intervention. In addition, qualitative interviews were also conducted with facility managers and key stakeholders to better understand the perceptions of the Beyond Bias program. Next slide. Okay, we presented a lot of information about the different data sources in a short amount of time, so feel free to ask additional questions or points of clarification in the chat, and we'd be happy to address them during our Q&A session. I want to spend a few minutes now talking about some of the key outcomes and variables of interest that were used to evaluate the Beyond Bias intervention. Next slide, please. Okay, the outcomes are going to follow this framework, which we use to group these different outcomes into this causal framework. And you'll see us reference this diagram again when we share results. I'll talk briefly what's inside each box in the next few slides, but first, let me walk you through this diagram. Let's start all the way on the left with the orange box, which involve the outcomes associated with provider attitudes and beliefs. Since the Beyond Bias intervention is targeted to health providers with the intention to make them less biased, we hope to see direct changes in providers' attitudes and beliefs. This, in turn, should affect changes in patient-centered care for FP services, which are the outcomes that you see in the blue box. And changes in patient-centered care should affect the types of methods received, which are the outcomes in the green box. And finally, the combination of the blue and green boxes, patient-centered care and FP methods received, would affect how clients perceive treatment of FP services obtained from their interaction with their provider, which is the gray box that you see in the bottom. And you'll see that in each box, there are different outcomes, but also different data sources that were used as part of the evaluation. And I'll talk about these outcomes in more details right now. Next slide, please. So for provider attitudes and beliefs, our main outcome here is the unbiased index. We used 47 different statements in which providers agreed or disagreed with, and these are statements such as unmarried women should not be using contraception, or women without children should not be using long-acting methods. And all these statements fall within different categories or sub-indices that look at FP care-specific beliefs, underlying beliefs, professional environment, and community factors. We also record whether providers would restrict a method based on client characteristics such as age, marital status, or parity. Next slide, please. For patient-centered FP care outcomes, we have 3 different data sources, the client exit survey, mystery clients, and the DCE, the discrete choice experiment tool, which all record whether clients were able to receive services that day and whether they were counseled on a full range of methods. We also have the essential questions index, which looks at clients' preferences for FP methods, spacing, and whether they have any questions for the provider. And finally, we also assess the method information index, which I think most of you are familiar with, that looks at whether clients were informed about other methods, side effects, and what to do if they experience those side effects. So our preferred data source here is the mystery client. And the reason for that is that recall can be an issue with real clients. In addition, mystery clients are trained what to look for and how to record this information. And therefore, we believe that the data recorded by mystery clients will be more accurate compared to real clients. Next slide, please. Okay, for FP methods received, the client exit survey is the only data source where the clients receive actual methods. And therefore, this is our preferred data source. Mystery clients were asked to record whether they thought they could take different FP methods based on the FP counseling session in the clinic. So we do have a proxy for methods received with the mystery client data source. And in the provider survey, the DCE tool, the discrete choice experiment, providers recorded which methods would be dispensed based on the different hypothetical clients presented to them. So for this particular outcome domain, we coded whether clients received any method, received their method of choice, and whether they received long-acting methods. We wanted to take a closer look at LARCs and injectables because we found evidence of method bias from our formative work. So it was important for us to take a closer look at the effects of the Beyond Bias intervention on long-acting methods. Next slide, please. And finally, for perceived treatment, we developed an index based on 29 subjective questions from the client exit survey and 22 questions from the mystery client debrief survey, which looked at things like, did clients feel like they were treated with respect? And did they feel like they could trust the provider? We also looked at whether clients felt being judged or scolded by providers and whether they would recommend the provider to their friend. Our preferred data source here for outcomes associated with perceived treatment is actually the mystery clients here. The main reason for this is that we are concerned about social desirability bias with real clients. We know that clients often overstate the extent to which they enjoy their experiences, whereas mystery clients are trained on what to look for and can respond more objectively. All right. At this point, I'm going to pass the mic to Zach to share the main results from the evaluation. So Zach, over to you.
Hi, everyone. I just want to warn you, my internet has been dropping out quite a bit, so it's highly likely that it could drop out again. Hopefully it doesn't, but we'll see how it goes. Next slide. Okay, so I'm going to talk about the results. So I'm going to follow this framework for the full results section. We're going to start with provider attitudes and beliefs. And remember, the provider survey was the main source for this. The unbiased index was our primary outcome for this domain. Next slide. Okay, so this is plotting the difference between the intervention group and the control group on the unbiased index. And what we see here is about
It seems like we're losing Zach, unfortunately. Hoping he's able to connect back. I think we can all relate to the challenges of technology. Please bear with us. We're trying to figure out how to get Zach back. Maybe he's able to dial in directly or figure out how to proceed. Bear with us.
I'm back. Next slide. Sorry about this, everybody. Brom, really, it might be better for you to step in at this point. My internet is just dropping off. So if it, I don't know. What do you think?
Why don't you try, Zach?
I'll try and keep going.
Yeah, if you get kicked off, try also joining from your cell phone, from your mobile phone via Zoom. That might give you a stronger connection, but give it a shot. See if you could kind of present some of the main results. And if you drop off, I can try to kind of jump in on some of the key points associated with these findings.
Sounds good. Sounds good. So the key takeaway here is that all the countries had a very similar effect on improving attitudes and beliefs, similar across countries, about a 0.7 standard deviation improvement. Next slide. And we can just go to the next slide also, just to save time. So we also asked providers if they would restrict a method based on whether a client was too young, unmarried, or didn't have children yet. And what we see is this is plotting the share of providers that said they would do that by treatment group and control group. And what we see is the intervention reduced the share of providers that said they would restrict methods based on these characteristics. This is again for all countries pooled. And we find similar results when we look at each country individually. Next slide. Okay, let's go to the patient-centered FP care outcomes. So remember, our main data source, or our preferred data source for this, is the mystery clients, although we measure it with these 3 different data sources. And our primary outcome here is the counseling on all methods outcome. Next slide. Okay, so this is again plotting the difference between the intervention group and the control group. A positive coefficient here is an improvement as a result of the intervention. I'll start with the mystery clients results here. And so what we see is for received services that day, keep in mind that all of our mystery clients pretty much received services. So there wasn't really much room for improvement here. On the counseling on full range of methods, we see an improvement that with the mystery clients that's significant at the 10% level. And then we also see that clients were asked more questions and they were provided more information about the methods. And then when we look at the exit survey data, we also see the same pattern here where there was an improvement in the number of methods counseled on, the number of questions asked, and the method information index. Next slide. Okay, we see that these improvements were mostly driven by Tanzania and Pakistan. So in Tanzania and Pakistan, we see improvements in both the exit survey and the mystery clients on most of these outcomes. In Burkina Faso, very limited improvements, especially in the mystery client data. Next slide. Okay, let's go to the family planning methods received. Remember that the client exit survey is the only data source for which we actually measure this outcome. We have proxies for this in the mystery clients and the provider survey, but they don't actually take a method in those sources. So the received modern method was our primary outcome for this as well. Okay, next slide. Okay, so with all countries pooled, when we look at mystery clients, we see this improvement in the mystery clients' perception of being able to take a method. They didn't actually take one. We asked them if they thought they would be able to take these different methods. And the
Ram, are you able to jump in?
Yeah, it seems like we may have lost Zach, so I can kind of jump here. So when we look at the outcome domain of FP methods received, there are no clear effects on methods dispensed. When you kind of look at the different data sources from the exit survey, when you look at modern methods, LARC injections or method of choice, no real difference between the control and intervention group. The mystery clients, you can see that the 95% confidence intervals suggest that there are trends of an effect, a positive effect measure. But again, they kind of touch that zero, which means that, again, you're not seeing a lot of clear effects. And within the discrete choice experiment, kind of these hypothetical scenarios, we did see some statistically significant improvements on whether providers would provide those modern methods. Next slide, please. This is kind of the breakdown between the various countries. And what's interesting to note here is that you are seeing statistical significant results among the mystery client data source in Tanzania. So a lot of the pooled effects that we see associated with epi methods dispense are primarily driven in Tanzania. And you can see that more pronounced with the mystery client data source. Next slide, please. This is kind of a breakdown.
Ram, I'm back on my phone. I think this will probably work.
All right, go ahead, sir. We're at the method mix by age group here.
Yep, I can see. So the key takeaway from this graph is pretty complicated. So I don't want you to look at it for too long. But what we're seeing here is there's really not much difference between the types of methods that were dispensed in the intervention group compared to the control group for any country or for any age group. So really not much change in method dispensing. Okay, next slide. Okay, now let's move on to the perceived treatment. So remember the mystery clients were our preferred data source here, and this perceived treatment index was our primary outcome for this data source. And the perceived treatment index was constructed based on all these subjective questions that the mystery clients and real clients responded to. Things like, did you feel like the provider treated you with respect? Did you feel like the provider, that you could completely trust the provider? Things like that. Okay, next slide. So what we see is in the mystery client data, there's a significant improvement in the perceived treatment index. So clients felt like they were being treated better in intervention groups compared to the control group. They're also more likely to recommend to a friend. In the exit survey data, we don't really trust this data quite as much for this type of outcome because of social desirability bias and the known challenges in measuring client satisfaction with exit surveys. So we like the mystery client data better for this. Next slide. When we break this down by country, again, we see that most of these positive improvements in the mystery clients are driven by Tanzania and Pakistan, with not much change happening in Burkina Faso. Next slide. Okay, so far we've seen that clients were treated better, they were counseled on more methods, provided on some more information, but not much change in method mix. So that's for all women 15 to 24. Then if we want to break this down and look at the disparities that we were interested in, so married women, are they getting treated better than unmarried women? Are younger women getting treated worse than older women? That's kind of another research question that we looked at. And so next slide. Okay. So I'm just going to summarize these results for you. So what we find is that the average effect of marital status parity in age on the outcomes we were interested in just wasn't quite as large as we expected going into the study. So we expected these things to have a big impact on the outcomes we were looking at, but that's not what we were seeing. Stop the video. So what that means, and so we also find that the improvements that we see for the intervention happen not just for the target group, not just for young women or unmarried women or women without children, but for all types of women. There's some suggestive evidence that in the control group, there was a disparity for nulliparous women that was eliminated by the intervention. But this is inconsistent across data sources and only present in the mystery client data. Now, we do find some evidence that bias still exists in the qualitative data when we look at these qualitative interviews, and that providers are still doing some biased things. It's just in the quantitative data, the extent of it was not as large as we expected. Okay, next slide. So I'm going to go through these really quickly. They're fairly complicated, and I just told you kind of the main takeaway from them. But the way we analyze these disparities is we plotted the difference between the intervention, between the young women and the older women on all the outcomes we looked at. And so what we're seeing here is that a positive coefficient means younger women are doing better, and a negative coefficient means younger women are doing worse. So with all countries pooled, what we're seeing is that younger women were really not doing worse in the control group on a lot of these outcomes to start with, and there wasn't much change happening in the intervention group. Next slide. So for marital status, we're really seeing the same thing. Not much of an effective marital status on the outcomes that we're looking at, and not much of a change in the control group. Next slide. And with parity, very, very similar effects. So there's really not much going on here. And so what that means is that there wasn't this huge gaps happening between these groups to start with, so there wasn't much room for the intervention to reduce these gaps. Next slide. And so far we've been looking at the effect of age, marital status, and parity in isolation. So that means kind of controlling for the other factors. But we do know that the combination of these characteristics is often what's really important. And so marital status might be really important for a young woman, but might be less important for an older woman. And parity might be important for a married woman, but might be less important for an unmarried woman. And so we analyze these kind of intersectionality, these characteristics, but we do have limited statistical power to do this. So these analyses should really be interpreted with caution. So we only had 40 mystery client visits for each profile per country. And so we just didn't have a lot of ability to look within those 40 to assess intervention effects or differences across profiles. Also, some profiles were just really rare. They didn't come into the clinic very often at all. So like I said, interpret these results with caution, but what we do find is that women who are married and do not have children, they're the ones who receive the worst care when ranked against all the other profiles. And the intervention impacts were particularly large for this group. This is in Tanzania and Burkina and Pakistan only, not in Burkina Faso. And qualitative evidence revealed that contraception was generally thought of as more appropriate for young women who are also students. And so that kind of shows that there's this the intersectionality goes beyond just age, marital status, and parity. Being a student is also something that providers take into account. And there's probably lots of other things as well that intersect with these different characteristics. So it ends up being a very complex decisions that providers make. Next slide. Okay, so I'm going to go over this super quick. What we did here is we plotted the outcomes for each profile for intervention and control. And that allowed us to kind of see what, if there were any particular profiles that were doing really bad on the outcomes or any particular profiles experienced particularly large benefits. And so if you want to look at disparities here, you would compare the red bars. The red bars are the control group level of the outcome for each profile. And then the blue bars are the treatment group. So if you want to look at an intervention impact, you would compare the difference between the red bar and the blue bar. And so what stood out to us is that for the married and nulliparous women, the red bar tended to be particularly low, and the difference between red and blue tended to be particularly large. Next slide. And so in order to analyze this in a little more detail, we ranked all of the profiles based on these different outcomes that we are interested in. And what we're seeing is that the married and nulliparous women tended to be lowest. This is ranked from lowest to highest, tended to receive the worst outcomes on all these. And so the older married and nulliparous were actually at the bottom, both in the exit survey and the mystery client data. Next slide. And then we also ranked them based on intervention impact, largest to smallest. And we see that the married and nulliparous women also experienced the largest benefit from the intervention on these outcomes. This is all for Tanzania so far. Next slide. So then we do the same thing for Pakistan. Next slide. And we find similar results where married and nulliparous women tended to rank the lowest. Next slide. But then also they experienced the largest benefit from the intervention. Next slide. And in Burkina Faso, there was really no clear differences across profiles or particularly large effects for any profiles. Next slide. Next slide. Next slide. Okay, let's get into some of the qualitative results. Remember, we did qualitative interviews with providers, clients, managers, and stakeholders. Next slide. So in Tanzania, and this is really true across all of the countries, providers were very positive about Beyond Bias. They seem to really like it. In Tanzania, many spoke about how they're about changes to their knowledge and attitude as a result of the intervention. Some facilities even documented workflow changes, things like prioritizing young clients for faster services, new youth-friendly hours. There were some challenges. Policy and program stakeholders found it challenging with all the different partners that were engaged to kind of just keeping that together. Providers also mentioned some implementation challenges, things like limited space and staff shortages. Next slide. There was widespread enthusiasm about scaling up the intervention. People thought this should be done by the government. And then, in both control sites and intervention sites, we still found instances of biased things that happen to young women or unmarried women. And so there's still, bias still persisted even in the presence of the intervention. Next slide. In Pakistan, again, providers really liked the intervention. In Pakistan, it's a really different environment where these are private providers that work by themselves in their own practice. They don't have the same network of providers to communicate about stuff with. And so they really liked to connect. It allowed them to connect with a lot of like-minded providers to talk about these interesting topics. But it's also really challenging to work with the private providers because, for them to participate in the intervention, it pulls them away from their practice. They also documented things about their knowledge increasing, especially with respect to the use of IUDs. They documented modified approaches to counseling, things like focusing more on informed choice and not denying services to women. And in Pakistan, the social norms are just really strong, especially around unmarried women, and they found that the intervention gave them more courage to resist some of these social norms. Next slide. Again, they were enthusiastic about scale up. And in Pakistan, especially, we found some evidence of persisting bias behavior, especially with respect to refusing services to some certain types of women, especially unmarried women. But even in the presence of this, clients that we interviewed they really liked the services they got. They had a high degree of satisfaction, but they all thought that certain types of women who came in might not get good care. Next slide. In Burkina Faso, again, providers really enjoyed participating in the intervention. They documented things like their knowledge improving and their counseling behavior changing. They also, similar to Tanzania, changed some of their operating practices, adding new youth-friendly spaces and expanded hours and things like that. In Pakistan especially, there were some structural challenges. Providers were really busy in Pakistan, in Burkina Faso, and they documented space constraints and commodity stockouts as issues as well. Next slide. Okay, so now I'm going to move on and talk about the cost of the intervention. So we had Pathfinder record all the costs of implementing the intervention for 12 months. And then we broke it down by cost per clinic, cost per provider, and cost per client exposed. So one thing I want you to notice is that we also list the percent of the total for each of these items in the top panel here. And rewards was a huge portion of the total cost. And we knew that was going to be the case going in because we had enumerators stationed at the facilities for 12 months straight. That's just a lot of time to pay somebody to do that. And so that's not really a scalable part of the intervention. And so I broke down costs both by total with enumerators and without enumerators. Just because we know that we'd have to find a cheaper way to do that for scaling. Now, the cost per clinic with enumerators in Tanzania was about 5,400. It was about 3,500 in Pakistan, and about 6,000 per clinic in Burkina Faso. And the client flow was just much larger in Tanzania than it was in Pakistan. Pakistan just has only one provider, and so the cost per provider and the cost per client was much higher in Pakistan just because of fewer providers and fewer client flow. And then when we do it without enumerators, then the costs get cut roughly in half for these different countries. Next slide. Okay, so what did we learn from this evaluation? Next slide. So the intervention led to less biased attitudes and beliefs in all three countries. This is a pretty clear finding. Then in Pakistan and Tanzania, the intervention also led to more comprehensive counseling, better treatment from the perspective of the clients. But all these outcomes were small and mostly insignificant in Burkina Faso. We do find limited evidence of changes in family planning method uptake and the types of methods received, which is kind of surprising to us. And then also not much of an effect on method of choice, which is a really important outcome. Now, this is mostly explained by the fact that there was just very little room for improvement in these outcomes because these outcomes were already very high in the control group to start with. Most women who came into the clinic received the method, and most said it was their method of choice. Now, the intervention did not change the effect of age, marital status, or parity on family planning outcomes. Improvements in counseling and perceived treatment occurred regardless of age, marital status, and parity, although there is some evidence that there was a disparity for married and nulliparous women that the intervention helped with. Next slide. Okay, so the intervention was most promising in Tanzania, where we see consistent improvements in pretty much all of the outcome domains, including method dispensing, and it was consistent across data sources. Engagement in Tanzania was also very strong. In Pakistan, the intervention definitely showed promise, although effects were not as consistent across data sources, and there was no impact on the method dispensing outcomes. It was also very challenging to work with the private providers. Initially, there was a lot of refusal to participate in the intervention, so it was just harder to keep these private providers engaged, whereas the public providers are all associated with a clinic that you can kind of engage them through the clinic. It was least promising in Burkina Faso, where we do see, and actually, let's just go to the next slide to talk about this. So in Burkina Faso, we see that there was very similar effects on attitudes and beliefs compared to Tanzania and Pakistan, but not much change in the other outcomes. And so this could partly be that just bias was lower in Burkina Faso to start with. And there is some evidence of this in the quantitative data. Burkina Faso had the highest unbiased index, so they had the attitudes and beliefs were the least biased in Burkina Faso to start with. And instances of bias were just really rare in the qualitative data as well. We also find that the providers we interviewed at Nline had engaged less with the intervention compared to the other countries. And so about 65% of the providers had attended the summit when we went at Nline. And this is mostly because new providers were hired, so they weren't available to attend the summit. They weren't at the clinic when the summit was happening. And so they didn't participate quite as much as in the other countries. There's also some systemic issues, things like the qualitative interviews revealed that providers were just really busy, didn't have space for privacy, had some method supply issues, things like that. So I would say that this is still kind of an open question. We're not really exactly sure why effects weren't as large in Burkina as the other countries, but these are kind of some of our potential explanations. Next slide. So we also find a lack of change in method dispensing. And so, for the uptake and method of choice outcomes, there wasn't really much room for improvement here anyways, because these outcomes were already so high in the control group. Something like 90% of women got a method, and most of them thought that that was their method of choice. Now, it's unclear why counseling improved, but the types of methods dispensed did not improve. So we know that women were counseled on more methods, but there was really no change in the types of methods that were dispensed. And so this was kind of surprising to us. So one explanation is that women could just be already receiving their method of choice, and even though they got counseled on more methods, they chose the same method that they would in absence of the intervention. Now, we don't think this is particularly likely. We think it's what we think the explanation is that providers counseled on more methods, but they continued to encourage the same methods that they would in absence of the intervention. And we do find some evidence of this in the data, where there was a lot of encouragement that was similar across intervention and control arms. There wasn't much change in encouragement. So this could be one of the explanations. We do find that mystery clients were significantly more likely to think they could take an expanded range of methods in the intervention facilities compared to the controlled facilities. And one thing that's really important here is we assigned them a method of choice. They had a preference for a method. And so they thought they could take their method of choice more often in the intervention facilities. So this is certainly promising, but it's not necessarily, it's hard to interpret because they didn't actually take a method. Next slide. We are also surprised to find that age, marital status, and parity didn't have as large of an effect as we thought going into the study. So one of the things that this suggests is that any intervention that targets youth who are already coming into the clinic in our study is unlikely to lead to a large reduction in disparities for young women that we observe at the population level. And so what this means is that women who come into the clinic that doesn't seem to be what's driving the disparity. It's the young women who don't come into the clinic, who maybe are dissuaded from coming into the clinic because they think they're going to get biased care. That seems to be what's driving the disparity. So the subset of women who come into the clinic could be the most confident, or their situation might be less likely to get biased care, and because of their situation, they might be more likely to get their method of choice. So another explanation for this is that most providers in Tanzania and Burkina Faso had already received training from Pathfinder on youth-friendly services, and so maybe bias had already, or the disparities that we might have observed before that training had already been improved. In Tanzania and in Pakistan, women who are married and do not have children did receive the worst care, and there's some evidence that we improved this. And so when we look at the intersectionality of these different characteristics, there may have been an improvement for that particular group, but limited statistical power then. Next slide. Okay. do we really care about the positive aspects of this intervention, reducing bias and making clients treated better when they come into the clinic, if it doesn't change the types of methods they get? So I would argue definitely yes. And I kind of think of this as the improving care and the way women are treated is a necessary but not sufficient way to reduce the unmet need for young women. So improved attitudes and beliefs and counseling quality. This could get more women that might experience bias or might be worried about bias to come into the clinic. And so disparities in FP uptake seem to exist because young women avoid the clinic in fear of experiencing bias. And so only like 8% of our clients were 15 to 19 years old, and that was heavily skewed towards 19. Very few 15 and 16-year-olds. Only about 6% didn't have a child. And in Pakistan, less than 1% were unmarried. And so these are groups that they don't come into the clinic because they know they're not going to receive very good care, or they expect they're not going to receive very good care. So as the intervention is around longer and providers start, or the word gets out that providers might have less biased attitudes and beliefs, this could lead to more women that would traditionally experience bias to start coming into the clinic and seeking care. Next slide. Okay, so I've talked about most of these limitations already, but one of the key limitations of this work is that provider bias is really hard to measure. It's hard to define. A lot of people have a different definition of what it is, and because of that, it's really hard to figure out a good way to measure it. Another thing is that method of choice, which is arguably the most important outcome for a woman coming into the clinic, is also really hard to measure because of social desirability bias. A woman might not know what her method of informed choice is because she didn't receive all the information, and so it's just really challenging to measure that. And in our data, most women thought they received their method of choice. We also didn't have enough statistical power to explore our intersectionality analyses. Our surveys all relied on self-reports, and we didn't have any baseline data for a lot of our outcomes. And then one thing that I think is really important is we didn't have data at the community level, so we don't know what's happening to perceptions at the household level and at the in the community, if perceptions are changing about whether or not providers in your community are biased. So I think that'll be an important piece of next work. Okay, over to you, Lydia.
Well, thank you so much, Zach. I must commend you and Bram actually for weathering that signal interruption with such poise. Teamwork makes the dream work for sure. So let's now focus on future work and what areas we reflected on or we think need more work. I think you will all agree with me by now that we've learned a heck lot about bias from this investment, but the truth is there's still a lot more work, a lot more to learn and a lot more work to be done. For one, as Zach has pointed out, one key area for future work should explore coupling beyond bias model intervention with community outreach efforts. And given that the beyond bias work was mainly facility-based, it's totally possible that young people were unaware of the changes that were occurring or happening at the facility. That probably information about facilities that were offering better services did not percolate or diffuse quickly enough through the community. As such, it would be interesting to actually assess if coupling the model or the beyond bias model with rigorous community outreach would lead to a significant change in FP client volume. Second, it would also be useful to measure effects of beyond bias intervention at the community level, as Zach again has mentioned. That is, try to understand as providers' attitudes and behaviors shift, do we see any changes in community perceptions of bias, or care-seeking habits maybe, or even it would be interesting to look at or be able to assess if women tend to actually seek care at better performing or less biased facilities. Do we see really that drive happening? Furthermore, how long does it take for these changes to really be realized at the community level? So this is all to say that we spent a lot of time and effort trying to, get into the mind of the provider and understand what drives their biases, but more is also needed at the community level for us to be able to understand what is going on there. That, and related to the point I just made about focusing on the community level, social network analysis would be helpful to better understand how provider interactions with clients at the facility are connected to community level perceptions. For instance, it would be valuable to understand when a young woman says provider bias is a deterrent to her access to contraception. Is it because she went to the facility and was turned away, or was attended to but treated poorly, so she doesn't want to go back? Or was she denied a method of her choice, or maybe given a method that she was happy with at the time, but suffered side effects later on and felt misled in retrospect? Or is it that maybe her peer or her friend had these experiences and shared them with her? Or could it be that she's suffering from internalized bias given the stigma in our community towards her sexuality or herself being sexually active? So certainly, a nuanced understanding of these aspects would be beneficial to help us better target the intervention and respond to this challenge of bias. Fourth, as we all know, bias is intersectional. And as you can see in our work, we didn't have the statistical power to be able to clearly illuminate what profiles of clients experience the most bias. And this would be very important for us to be able to understand not only how to target the intervention, but also to be able to reach the most vulnerable with the intervention. So that element of intersectionality, because we know it's not just about age or marital status or parity. What we're learning from this work, and especially from the qualitative, is sometimes even beyond, it goes beyond age, marital status and parity, and goes to is a girl in school or not in school. So all these aspects we need to really be able to look at holistically, all the aspects, intersectional aspects, or aspects that intersect, to make a certain profile of a client, or to make a certain client experience more bias, so that we'll then be able to respond. Fifth, we need reliable quantitative tools to measure provider bias, and especially when it comes to client feedback. I cannot emphasize this enough. Finding cost-effective ways of collecting credible, reliable, client-facing data has been a real challenge for us. And even though we've made some dents on this subject, more work is certainly needed in this area. And finally, the last 2 points on this slide touch on the question of method mix as it relates to informed choice. So for instance, does comprehensive counseling lead to improvement on method choice? Always? Sometimes? Or under what situations, or in what situations? Also, can we better measure, how can we better measure if clients receive their method of choice? These questions had me thinking back about youth priming, which is a concept that came up during our prototyping design stage. And it was driven by an overwhelming response from providers that young clients especially are more reluctant to choose a method, even after being counseled on all possible choices. So there is a tension there worth exploring further. So when we say a provider encourages a certain method, we need to really understand, as a provider, what are you required to do if you provide comprehensive counseling and a young person waits on you to guide them? Is there bias? Is there no bias? What does that mean? So there's definitely a question there for us to explore. Next slide. So before I hand over back to Gwen to moderate Q&A session, I want to take this opportunity to truly appreciate my rock stars who are the Beyond Bias project team, from the evaluation team to our design team at Ylabs, our segmentation experts at Camber Collective, and the dedicated implementation team at Pathfinder here in the US and in Tanzania, in Burkina, and in Pakistan. I salute you all. This work was a heavy lift, and it's demanded way more than the call of duty from each of us. I thank you for your diligence, your hard work, and your commitment to the cause. Back to you, Gwen.
Okay, thank you, Lydia. And I also just want to thank everybody on the Beyond Bias team as well for 5.5 years of just tremendous work that has really evolved our overall field's understanding of bias. So I did want to switch over to Q&A. We have received a ton of wonderful, interesting questions. Please keep them coming. The first one, Zach, I'm going to direct to you, which is more a clarifying question before we get into some of the meatier ones. So the question, I don't know which slide it refers to, unfortunately, but I think the question still holds. It says that third bullet is confusing. How could intervention eliminate disparities in a control group? Does this mean that there were background changes that affected the control group?
Yeah, so we wouldn't expect the intervention to eliminate disparities in the control group. What we observed is that disparities were not there in the control group to the extent that we expected. Now, maybe it's to the bullet that talked about the training that providers already received. And so we do know that Pathfinder had already provided training to a lot of the providers, including those in the control group, prior to the start of the intervention. And so some of those disparities could have been eliminated already as a result of that.
Okay, thanks, Zach. We also, I'm just gonna kind of consolidate because there were at least 3 different questions I saw from participants around what we know about kind of provider type, age of provider, you know, kind of male, female providers, and whether that has any bearing on in terms of the results we saw. So Zach, I don't know if you can respond.
Sorry, could you repeat that? Provider type?
Yeah, so there were several questions that I'm kind of lumping together because they're all interrelated in my mind, which is how might provider characteristics have some type of influence on the results, either kind of positive or negative. So for example, if we looked at, you know, male providers versus female providers, or different types of providers, or, you know, age of provider, do we see anything that kind of stands out?
Yeah, I think that's a good suggestion, and that's not something we've looked at. And so, you know, it's possible that maybe older providers are more set in their ways and they're less amenable to change. And so looking at heterogeneity by provider characteristics and see if some of these results had a stronger effect, that's certainly something we could do. Now, we don't actually know what provider the mystery clients or the exit survey clients went to, because we didn't record that information. That was all de-identified. So we can't do that analysis for the client-facing data, but we could do that analysis for the provider survey. So that is a good suggestion.
Great. We also received 2 different questions. This might be partly for you, Zach, and also partly for Lydia, and I think they're really good questions, which was just asking about potential implications of the fact that this was layered on top of existing, you know, kind of Pathfinder host projects that were already striving to improve, you know, the responsiveness of contraceptive services for adolescents and youth. So there was that question. And then another question was just, were the control sites also part of the host projects?
Yeah, so I can't speak as much about the differences between the interventions that existed prior to Beyond Biased and the actual intervention of Beyond Biased. I think Lydia would be best to discuss that, but I can say that intervention certainly could have, the fact that there was already pre-existing interventions certainly could have dulled the effect of this intervention. And had this been implemented in a setting where there had been no intervention about youth-friendly services already, we may have seen different effects. And my expectation would be, larger effects because the interventions kind of have the same goal.
Yeah, I would agree with you, Zach, on that. But also point out that we did actually implement in Pakistan, but didn't have a platform project. And so when you look at the two, there is something to be learned from that, in the sense that, yes, you can have, this intervention has definitely a potential in areas where bias is more, or where there's not much training going on providers. But I think the point I want to make more so of is that we still see, even with the training of providers, we're still struggling with provider bias, even with these countries in Burkina and Tanzania, where the platform projects have been there for a long time. They've been working for a long time trying to change provider behavior. So the fact that even in those two countries, we're struggling with bias, as recorded in qualitative results, and as well as our interactions with providers during the summit, it means that yes, this intervention or training alone, again, I still feel very strongly that this intervention goes beyond training, and it's needed, even in areas where we're doing training. That's what I would say.
Okay. The next question, again, several people raised this, was around, if we're looking at availability of contraceptive methods, supply issues, how much do we know about that in relation to the findings? Because I think many people are hypothesizing that, if some methods are not available, I think it was Martha maybe was even pointing out, like, for Burkina Faso, others that have worked there, knowing that there are often stockouts of certain methods. So how might that be influencing some of the outcomes that we saw, both in terms of what methods were being counseled on and also dispersed?
Sure. So we do know that stockouts were an issue for some types of methods, and sometimes we asked providers in the provider survey, in the last month, have you had any supply issues with method X? And so we found something like some of the methods were up to about 20% of providers reported that there was a stockout. So this is certainly a problem that does happen. Now, this was balanced between the intervention group and the control group. So what that means is it's not really going to affect the differences that we're documenting between the intervention group and the control group. And so I would say this could affect some of the kind of the levels of the outcomes. And so if we're seeing that, maybe the counseling on full range of methods was lower than we would expect because of stockouts. But the difference between intervention and control should not be affected by the fact that there were stockouts. At least not affected very, very much. There is, some complex ways in which it could be affected, ceiling effects or something like that, or floor effects. But for the most part, the differences we're documenting shouldn't be biased by stockouts.
Okay. The next question, which might be more of a Brahm question, do you have any age disaggregated facility level service provision data that shows any uptake on the use of services and/or changes in method mix at facility level to complement the evaluation findings?
Yeah, good question. We did collect a lot of FP service statistics as part of the evaluation. And as we look at the trends of overall kind of FP methods dispensed, but also the method mix, there wasn't a lot of change within the 1 year time frame of the intervention. So when you compare control and intervention, we don't quite detect that difference. And I think part of that challenge has to deal with the fact that this is a facility-based intervention, kind of seeing the effects happening within a relatively short time frame. 1 year for behavior change program is quite short. And there's no kind of that linking with the community notification that you've got facilities with this intervention. So because of the short time frame, we didn't see a lot of those changes in terms of method mix based on our FP service data.
And I will just add that that's consistent with the exit survey data. So if you compare the You know, in the exit survey data, we don't see much change in the methods that women report getting. And then in the service statistics data, we don't see much change in the distribution of methods between the intervention group and the control group. And we can plot that back, a year or two before the intervention even started, and we don't really see much change over time after the intervention started.
Okay, thanks, Zach. Two questions, I would say both for Lydia. So one was saying the studies, wonderful, but a question whether or not the team looked at upstream bias in terms of bias amongst government officials, donors, etc.
Oops, I was muted. I appreciate the comment. No, we didn't. We didn't look at upstream bias. We were really focused on the provider. And I think one thing I want to really point out, the subject of bias is complex. It is very, very complex. We had to contain it to be able to dive deeper into it. And so for the scope of the project and the budget that we had, our focus was trying to really get to the mind of the provider, as I said, and we didn't really get to the upstream, although we do agree and that actually bias, at the government level and even outside the facility level, it definitely does play a role. What is encouraging though is the model that we came up with is adaptable to other forms of bias, not just on FB, but in maternal and child health, for instance. So this is a model that you can adopt. So the behavior change mechanisms, that one of trying to get into, humanizing bias and empathy, building empathy, it will be the same things and trying to cut through the misperceptions and then somewhat recognizing change or recognizing a shift. All those are applicable, I find, even though we didn't focus on these other biases, upstream biases, that is, or these other categories of people. Thanks,
Lydia. Can you stay on for a few more minutes, because a few more of these are more probably geared towards you. So there were a couple of questions related to any specific insights related to LARCs or NSV. And then I think there was another, and then another NSV related question. Also, if you can talk about motivators and barriers related to facility-based service providers who provide counseling related to voluntary surgical methods.
So specific to LACs is a question about what drives bias towards LACs for you?
It doesn't, the question is a little open-ended. It says any specific insights related to LARCs and NSV. And then the same person had asked the question around motivators and barriers related to counseling on NSV. So my guess is that this is coming from somebody that is probably working to try to increase access to
so what we learned from our formative research and design work about LACs is that particularly it depends with the context, obviously, and particularly in Pakistan, that is driven by the social norms of the need to prove fertility. And so there's an issue of fertility. And so when a young married woman or a newly married, a wed person, a woman goes to the facility, providers tend to discourage them from using a long-term method until they given birth. They'll encourage them, and they're sometimes even very kind in telling them, go give birth to a child or two and then come back. So that's what's playing out in Pakistan. In Tanzania, it was more related to fears about fertility again, but fears about ruining a woman's fertility. So there was that worry that a young woman may, if you're using hormonal methods, for instance, for some that are hormonal, that might have an issue. But also in Tanzania and Burkina Faso, there's the element of that you'll be more promiscuous as a young person and just go out and start having sex if, for instance, you have an implant. So those concerns. I would like to also note, though, that in areas we're working in, particularly in Tanzania, there were other programs that are ongoing that were working towards improving uptake of lax. And that has been ongoing for a couple years after the Missouri Choice Project that talked about the efficacy of lax in improving or preventing unwanted pregnancies among youth and adolescents, just given the fact that it's that dependent on user behavior. So there's that countercurrent where you have programs that are encouraging use of lax by youth and adolescents as to be more efficient or more effective, and they're incentivizing that. And providers are juggling. What we found is that providers are really juggling between the messages and the messaging that we're giving them. And the truth of the matter is, the more time we spend with providers, we learn that more of how our work is fragmented. Our work is fragmented as a field, and sometimes we can give them very conflicting information. And so they're trying to juggle and figure out what is happening at each time. But for the most of it, you find that any hesitation towards any particular method that a provider may have tend to lean either come from a social norm or a feeling about, their own provider's own values, whether it's you shouldn't be sexually active, or it's a worry that it will ruin your life or maybe affect your fertility, or it's actually driven by misperceptions or lack of understanding of methods. Another element of lax that we found was just providers not having the space, the structural factors we're talking about in Burkina. There isn't just room in the consultation room to give a method. And sometimes providers are not trained, well trained, and don't feel comfortable giving a method. So as a provider, when you have a young person come through the door and you don't feel comfortable giving an FP method, maybe IUD, or you don't have enough room or the equipment to do it, then you just offer other methods that you feel probably you're able to offer well. So it's a slew of a lot of information. I'll encourage the person who's asking this question to probably refer to our literature review, which is available also on our website. There was a lot of insights that came from that.
Thank you, Lydia. So this next question is for Zach. Did the study take into account changes that may have occurred in a second or third visit? For instance, perhaps there are no changes to their method in that one interaction, but with a few bias-free discussions, and a relationship is, a positive relationship formed between the provider and client, they're willing to shift. And maybe to add on my own question to this, I think others have been interested in what, if anything, we know about continuation, kind of to the same point. It's like how this may have a positive effect in terms of retaining young people for care.
Yeah, I think those are both really good questions, and based on how our data was collected, it was anonymous, and we didn't really have a good way to look at that. We didn't know what number of visit. We do know if it was their first time coming to the clinic, but we don't know how many other times they had come, and so it's not really something we can look at very well, unfortunately, although I do think it is a really important question. And I think continuation, obviously is incredibly important. We know that, coming in, maybe you leave with the method that you wanted, but you got really bad care. And so you don't want to go back to that facility to continue. And so that's definitely something that I think is worth looking at in the future, that we don't really have a great way to do that with our data.
Thanks, Zach. Lydia, I would like you to weigh in. There's actually quite a lot of questions that I would lump together around sustainability, scale, kind of future work. Do you want to take those? Do you want to try to reserve those for the second webinar that I know is going to be focused on the scale up guide?
I don't mind responding. Probably I can be brief, and then we can take we can
Okay.
continue the discussion in the upcoming webinar. Yeah, so we started with the end in mind. Bear in mind, Gwen was our program officer, so we started with the end in mind, and scalability of this intervention was of great importance. We applied the expanded criteria or framework to make sure that we were working with the resource teams that we needed at the country level throughout. Actually, from the inception of the project at the research stage, we worked with what we called advisory committees in country that included the ministries of health and other key stakeholders, including INGOs, local organizations, young people, to carry us or to talk through, or actually to walk with us through this journey. And so that's why we have a lot of excitement, even despite all the some of the questions that the evaluation is raising. There is just so much excitement in the country for the scale up of this work. And the reason is that people do understand, just based on the level of engagement we've had with them, ministries of health and countries do understand that there is a gap when it comes to addressing provider bias, and training and supervision hasn't really worked. And provider bias, the Beyond Bias model actually does offer something more, and they embrace that, which is such a gain for us. So there's that embracing. And as a matter of fact, in Burkina Faso, they are currently working with the Ministry of Health to integrate the Beyond Bias in the health system. So the secretariat that DSF, I think they call it, that provides guidelines on what kind of implementation goes in country, did welcome and invite Beyond Bias to actually integrate the model in their 2022, I think 2020, in the next 5-year plan in their country. And this goes to show you just the level of enthusiasm that there is. And then the enthusiasm, I don't want to say it's just a soundbite. I want to say it's a value add. So I would encourage a couple of things. One, that you think, when you think about the Beyond Bias model, you don't think about it in isolation. We isolated and went deep so we can learn so much. We've learned so much, and we're sharing this information, so we need to come up for air. So what that means is that this intervention needs to be integrated, as I've been saying, in other programs, existing programs. So you don't just take Beyond Bias and just go and implement it alone. If you want for it to work well, like we've said, integrated with community, community level or efforts, community mobilization efforts, integrated with other family planning, system strengthening, at the facilities. That's also very needed. Like I'm saying, sometimes it's very difficult, as some of you have pointed out, to claim that a provider is biased when actually they don't have a method, or they don't have the structures in place for them to give a method that a young person or anyone may be asking. So there's that level, needing to take this information and put it back and integrate it within the larger or larger programs is one thing that I really encourage. And I think the last point that I want to make is that we did struggle for sure with the rewards pillar of the model, and that was because it's not because, like Zach said, it's not because we went to it assuming that having tablets and enumerators in facility was not expensive. Trust me, we spent 2 years trying to figure out what way, what methodology, what mode could be more cost effective. We tried SMSs, we tried IVRs, we tried having tablets at facilities. It didn't work. The reason why it didn't work is a number of factors. Combination of young people's needs, which sometimes comes with low literacy levels. And so that was one challenge, that when you send this information through messages, they don't sometimes understand what you're talking about. So the need for someone in person there to do the interview is needed. The other thing we found out as young people, use of technology is not as straightforward. Sometimes, like, you have a diversity in Pakistan, there's sharing of phones, for instance. And as a young, newly married wed, it's not obvious that she will have access to her own phone. Sometimes the mother-in-law accesses our phone. So the issue of confidentiality then comes at play. So they say, when you ask them for their numbers so you can contact them later, they say, but you promised me confidentiality, you promised me, confidentiality. So why are you following me back home? So there's that, introduces that element. In Burkina Faso, what was surprising is that, we always assume that young people are go-lucky, happy, technology. There was a resistance in Burkina Faso in particular for young people to give their numbers. And this one was actually driven by, they say, we don't know who's going to take our number, where you go, what names, we leave our names on our numbers and what you do with them. There was that questioning. So there is a need. And one of the gaps is, as I'm saying, in trying to understand how to collect this evidence in a way that is credible. Let me say one more thing. We left tablets in facilities, and data falsification was quite something. Providers just got in and keyed in the numbers. So again, just talking about how do we collect this data in a way that is credible. One of the things we've tried to do, because we're aware, again, this is not scalable, is again work on a tool, because the question sometimes is on the tool. How many questions do you need to ask to really be able to assess bias? We started with 18 and we're excited, and it failed flat on our faces. I mean, when I say it failed flat on our faces, it couldn't detect nothing. So then it ballooned, the tool ballooned to 100 questions almost. And you can't really have 100 questions on an SMS or other things. So one of the activities, or one of the side projects we've been doing, is psychometric analysis to have a parsimonious tool. Hi, Zahir, if you're here, that will have fewer questions, maybe 6 or 12, a set of 12 questions that could be asked to be able to detect bias. But like I'm saying, these are work in progress. And more work is needed there. But hopefully, as COVID has sprung us and all of us are on using digital, whether we like it or not, with its challenges, maybe that's a push forward on, digital opening for being one of the successes. But yes, just all to sum up, there's a lot to consider. There's a lot of potential, and there's still a lot to consider.
Thank you, Lydia. Zach, an earlier question for you. What was the criteria for deciding the preferred data source for each stream?
Yeah, that's a good question. It was pretty subjective on our part. Just we thought about it, and we know, especially with these self-recorded measures, we know that it's hard for some of the real clients to report things that happened during the visit. Both because they might not remember, or they might not have been paying attention or looking for it, and then also because there's a social desirability bias issue where they don't want to say that the provider treated them bad or did anything. They don't want to make the provider look bad. And so that's kind of when we moved to mystery clients, and we knew that we had kind of trained mystery clients on what to look for. We had they also are trained to answer honestly about how they were treated. And so for some of those outcomes, we just felt like it was more accurate with the mystery clients. But it was really kind of researcher discretion there. But I do think that there's large literature on real clients not answering honestly about how they're how satisfied they are with their visit. And so I think that it was good that we had mystery clients to be able to analyze some of those more subjective outcomes.
Thanks, Zach. And I just want to call out, I do hope that there's a way to kind of capture the chat, because in addition to the questions, there's just been some wonderful comments, people that are doing similar work and sharing their own research or just observations. So it's a really rich discussion. Maybe pivoting, I guess this is for Lydia. There's a question about whether it says, given the very rich segmentation work that you've already done in the 3 countries, have there been any discussions with respective national institutions to include some bias reduction strategies based on that knowledge in pre-service training and instruction? surely that's a different type of intervention, but would be additional way to build on the foundational formative work you've already done.
If I get the question correctly, one of the ways that we hope to, because segmentation, again, there's a tension when it comes to segmentation, because segmentation is fragmentation of, you get more nuance, but you get fragmented information. And with this project, we're able to segment across three countries in 3 different regions. It's East Africa, West Africa, and South Asia. So the way we did our segmentation was unique in a way that we tried to make sure that these segments cut across those regions, although we did find segments that were particular and dominant in each country. So in that case, this makes it possible for any programs, and we are actually recommending this in our how-to guide, any programs that comes after us or the scaling of these projects, to use a profiling tool, which is, because segmentation analysis can be very time consuming and it's a large scale survey. But with that, we have a profiling tool, which is about 5 questions that you can use or folks can use to place providers, whoever providers they're working with, on whatever segment they are. And this project will be able then to tell you what characteristics or what kind of biases drive that particular segment. And that is one of the ways that segmentation work informs or can inform scale up. We definitely haven't, started on the scale up because we were still learning and just came currently developing the how-to guide for scale. But I think the questions that we've gotten a lot about segmentation is, how is it going to apply for, let's say we worked in Dar es Salaam, what happens when you go to the more rural regions in Tanzania, or when you leave Pakistan and you go to Bangladesh, how does the segmentation work? Those are real questions we're getting. And we've wrestled with that question, and we do have some suggestions that we're making, which is, we hope that the work that has been done and the segments that you find in East Africa will be more relatable to that region, and likewise for West Africa and South Asia. But we also still recommend some level of situation analysis and formative research, like anyone would do before they start a program, which then includes also the profiling tool to see whether there's something else that is coming to the fore that is different from the segments that we found, and so that you can, target the intervention to that particular segment. I just give an example of a different project, which is the impact project the Pathfinder did in Niger, and how that work was replicated in Senegal. So they did in Niger, they did a segmentation analysis that was nationwide, and that was supposed to develop a tool for providers to counsel clients. Like, what are some of the ways that, how do you tell the client you have, and it directs you to shorten what methods to counsel them on. And that tool and that segmentation analysis was being replicated in Senegal. But what really ended up happening is that with the evaluation, what situation analysis, they realized there was a particular category and segment in Senegal that didn't seem to sit in well with the Niger. So they then added that particular group. So it's a similar scenario that we're recommending. So we've done the groundwork, but definitely you do need to do contextualization. I just hope with all what I've thrown out will help answer that question on segmentation. Try to hit all the points.
Thank you, Lydia. So I'm looking at the time and we only have a couple more minutes. So I do want to wrap up. I just, again, want to thank all of the participants for wonderful questions, great comments. Apologies, I know there were some questions we weren't able to get to, but just to note again that there will be opportunities for further discussion in the second webinar that's going to be on May 11th, where the Beyond Bias team will be launching the Scale Up Guide. So I just wanted to kind of wrap up from my perspective, as a donor, and kind of what is my takeaway. There's too many points to really kind of consolidate all of it, but just to say, overall, I just feel like there's been a tremendous amount that has been learned under this investment. in terms of the drivers of bias, promising solutions to address bias, but also all the work that was done grappling with questions in terms of measurement that, Zach and Lydia and I think Ram all alluded to. In terms of, going forward, I think that there are some key questions that we all have. Zach did a great job of raising them at the end in terms of implications, but just, we do know bias exists. That's been well documented in the literature, but we weren't necessarily seeing it necessarily show up in the ways that we would have thought through the quantitative client-facing data. So, is this a question of it exists, but we need to do much more work as a field to really understand how even one instance of bias might then spread amongst other young people at the community level, and therefore really acts as a deterrent for other young people to seek services in the first place. And I think the data just showing that some of the kind of population segments that we know that often do experience bias weren't really showing up that much in terms of the clients that were coming in, kind of speaks to that this phenomena that they're not coming in, and that maybe we need to be doing, looking at this from a different lens in terms of at the community level. The other is that I think that there's a lot of work that needs to be done around scaling these promising solutions, further iteration to address some of the challenges that we faced in collecting client-facing data for the rewards pillar, as well as, layering in complementary interventions on the demand side to make young people aware of the improvements that we were seeing in terms of service providers. So, service providers are saying that there have been changes in their own attitudes, behaviors. We're seeing improvements in the quality of service provision, but that's not necessarily translating into more young people coming into the clinic, primarily because they're not even aware that those changes have occurred. So I guess those are some key things from my side. And with that, I really want to thank all of the presenters and wish all of you a very good evening or a good day, depending on where you're located. So thank you very much.
Thank you, Gwen, and everyone for attending. We appreciate it.